you need something, Mr. Bravo?
Yeah, I need a cigarette.
I'm sorry, there's no smoking in the hospital. Your doctor can write for a nicotine patch.
Patches don't do anything. If I don't get a cigarette right now, I'm gonna kick some.
Oh, Green, what am I gonna do?
An excellent question, Dr. Johnson. Hopefully, by the end of this session, you, along with you, the viewer, will know what to do when similar situations occur. Managing the agitated or violent patient is a common dilemma for the psychiatrist, especially when one is working on call or as a consultant. I'm going to give you the skills you need to manage and assess these situations. But for now, let's get back to our friend Dr. Johnson.
Where is it?
In there!
Fear is a normal human response when there is a potential for violence. It may even be helpful in acting quickly if necessary. However, acting before thinking can lead to escalation of an already potentially volatile situation.
What do you want?
Get back in the bed!
Dr. Johnson,
Yeah?
the code green is in the next room.
Whoa there, Dr. Johnson. Clearly that is not the best way to manage this situation. Let's take a look at a more rational method. Here is a suggested mnemonic that you may find helpful. C stands for containment. The primary goal of containment is the safety of you, the patient, and everyone else. When you arrive, quickly assess the area. Make sure you have plenty of backup for if the situation escalates. Make sure that all other patients are cleared from the area. This is crucial. Also, make sure that you and the patient have easy access to the door. Nobody likes feeling trapped, especially the patient. It's not your job to physically restrain the patient. After all, if you get injured, who else is going to take call? Let's give Dr. Johnson another try, shall we?
Somebody, please tell me what's going on.
It was horrible. He said that if he didn't get any cigarettes, he would kick my... Oh,
What's his name?
Tony Bravo?
Cigarette!
I take it that's Mr. Bravo. Does he have any weapons?
I don't think so.
Notice how quickly and effectively Dr. Johnson assessed the situation. He ensured that he had backup. He located the agitated patient. He made sure other patients were cleared from the area, and he asked questions about weapons. Overall, he remained calm and did not make any snap judgments. Now that some safety has been established, let's move on to the next phase, which is assessment. Assessment does not mean theorizing about all the neuropsychological underpinnings of the behavior. Instead, it means determining if there is a recognizable disorder that merits treatment. Here is a brief and non-inclusive list of the things that can cause violent behavior. Did you get all that? You can also assess risk for actual violent behavior. The best predictor of future behavior is, of course, past behavior. Other risk factors include antisocial personality, substance abuse, psychosis, and baseline impulsivity. It's also important to rule out medical causes of agitation, including withdrawal and delirium.
What is he hospitalized for?
He's a 30-year-old male who was in a motorcycle accident. He has a tib-fib fracture.
Does he have a history of mental illness or substance abuse?
No, but he was intoxicated when he arrived.
I'm going to try to talk with him.
You got your bag, Dr. Johnson.
Not bad. Let's see how Dr. Johnson does when he meets the patient.
Hi, Mr. Bravo. My name is Dr. Eric Johnson. I'm one of the... Hey, put it down now!
You!
Put the IV pole down right now, or I will lock you up and throw away the key.
Go ahead and try.
Whoa there, Dr. Johnson. Certainly that is not the way to go about handling this situation. Clearly, safety needed to be established before any further assessment could occur. Dr. Johnson needed the patient to relinquish his weapon, but he went about it all wrong. Dr. Johnson has a closed body posture. He appears angry and confrontational, and he's blocking the door. He was gazing intently at the patient, which can be viewed as a threatening situation. He engaged in reciprocal actions and language that only escalated the situation. Let's give him another try, shall we?
Mr. Bravo, hi. I'm Dr. Johnson from Psychiatry.
Doctor who?
Dr. Johnson.
Do you want Dr. Johnson?
Well, Mr. Bravo, the staff up here called me to come talk to you. I think because they're a little scared for their safety and the safety of the other patients.
All I want is a cigarette.
You're making us scared with that pole. Would you put it down?
Fine.
Thank you. Would it be okay with you if I sat down and we could talk?
Fine.
Notice how much better he handled the situation this time. Please note the open posture, with his arms at his side, his sideways open stance, and his relaxed demeanor. He used intermittent eye contact. He asked directly to have the patient put down his weapon. Dr. Johnson was honest with the patient, so that he could understand where the health professionals were coming from. He kept himself on the same eye level as the patient, so that he wasn't standing in a threatening position. These simple techniques went a long way to calming the patient down.